Hello and welcome to the second in a series of forums dealing with the ongoing crisis in healthcare. These sessions are organized by the PSC Social Safety Net Working Group and its Task Force on Healthcare Reform. I'm Jim Perlstein and I co-chair the working group. The pandemic's driven home to all of us the chaos, inadequacy, and unsustainability of our healthcare system, even for those of us in the PSC who have close to the best of what's on offer. Our first session in December tried to provide an overview of the crisis locally and nationally. It also offered a synopsis of the jolting but consciousness-raising politics of the forced move of municipal retirees from the public Medicare program to a private for-profit Medicare Advantage Plus scheme, and what that forced move implies for healthcare policy down the road. Tonight, we first consider the history of labor's relation to the question of healthcare for the working class. Our presenter is Josh Freeman, Distinguished Professor Emeritus from Queens College, the Graduate Center, and the School of Labor and Urban Studies. We follow with a look at the cost-saving alternatives ignored in the recent push by New York City and the Municipal Labor Committee to get retired public employees off publicly provided health insurance and into the clutches of the private-oriented private sector. And, I presume to say that even these alternatives fall short of the system we're shooting for, namely single payer. Our presenter is Barbara Perez, Professor of Public Health Policy at Sarah Lawrence, Baruch College, former Director of Strategic Planning at the SEIU 32BJ Benefits Fund, and a consultant on health policy for the PSC. We'll conclude this evening's presentations with an examination of the health insurance options available to most working people and the impact their availability or lack thereof has on health and well-being. Our focus here being CUNY students, their families, and communities. Our presenter is Naomi Zudi, Assistant Professor of Public Health Policy at the CUNY Graduate School of Public Health and Fellow at the Roosevelt Institute. So without further ado, let me turn the floor over to Josh Freeman.
Thanks.
Let me just one more point, Josh. We'll use the time left at the end of the presentations for questions taken in the order they're received. Please use the raise hand symbol under reactions on the lower right-hand side of your screen, or enter your question in the chat. When we're done, we'd like you to complete a brief survey on tonight's forum and the PSC work on the healthcare issue. Links to the survey will be found in the chat. Please mute yourself until it's your turn to speak so as to minimize background noise. Thanks. Sorry, Josh. Go to town.
No, it's fine. Thank you, Jim, for inviting me and chairing this meeting. And I'm just delighted to be here. As Jim said, I want to just talk very broadly about the long history of labor's involvement with healthcare issues. And I'm not really going to focus on this specific issue that we're grappling with today of the effort to move people out of the retirees out of traditional Medicare to Medicare Advantage Plus. But it's interesting. You can use that issue to get a little bit of perspective, and I hope the history I give will give perspective on that. Because as urgent as this issue is, in a way, it's an issue that only recently would have arisen or made a lot of sense, because it's only recently that actually a substantial number of working people lived long enough and retired young enough to even have to worry about such a thing as retiree health insurance. I was born in 1949, and in that year, the life expectancy for American men was 65.2 years, and for American women, it was 71.1. So, at that moment, the typical American man got to collect Social Security for 3 months and then drop dead. So, retiree health insurance was not an issue. So in a way, it's a measure of progress that we're even talking about this, but the kinds of context for our discussion long predates this issue and goes back deeply into the history of labor and health issues. In the 19th century, and even going into the beginning of the 20th century, when labor thought about sickness and disease, the biggest challenge they thought about was actually not the cost of medical care. It was the loss of income. Very few working class people had any savings at all. And if they had them, they're extremely minimal. So the huge impact of the loss of income from sickness or disease was a disaster. And then, if someone died, besides the human tragedy, even the cost of burying someone was beyond the means of most working class families. So labor first got involved in the issue of health in trying to confront this problem of income loss and death costs for working people. And unions and ethnic groups and other working class organizations began developing sickness and death benefit funds. And these were a kind of form of self-insurance that was the really first engagement of the labor movement with health issues. As part of a union membership or as part of dues, you would become a member of one of these funds. And if you were sick, you could draw out funds to help support your family. And if a worker died, a member of a fund, the family would get a small payment to help with burial costs. And these funds, became an important attraction of unions. It was one of the things people liked about unions, and they actually provided a certain amount of stability for unions, because when workers lost their jobs in an economic downturn, instead of immediately dropping out of the union, many of them maintained their union membership because they didn't want to lose the sickness and death funds. So these kind of got built into the model, particularly in many of the craft unions in the early 20th century. Now, some of the burden was relieved in the World War I era as states began passing what we have today, workmen's compensation laws. And under workmen's compensation, if you have a work-related accident or disease, then it's a state-sponsored insurance system that gives you some income. But it doesn't help the problem if you get sick or have an accident separately from the job. So these union benefit funds continued well into the 20th century, and some continued today. Medical expenses was actually less of an issue because, first of all, most working class people didn't see doctors at all. And, there wasn't all that much doctors could do. And secondly, doctors tended not to charge that much if they had working class constituencies, practices. And hospitals all had charity wards, which is a place where people could go, or in New York, we had Bellevue. So it was really this income loss that unions first thought about until around the World War I era, when medicine improved, there were more practical benefits from medical care, and unions began getting more directly involved in the provision of healthcare. And two different sort of models developed. The first was the union clinic, and that really started here in New York in 1913 with the International Ladies Garment Workers Union, which set up a healthcare clinic. It was called the Union Health Center. And the idea was that for a very small fee, members of the union could go there and get diagnostic services, preventive services, and eventually therapeutic services, treatment at the clinic. And the union subsidized it, keep costs very low. And as the years went by, the clinic got bigger and bigger and bigger. It became a very big operation, and the scope of what it provided became bigger and bigger. This pioneer clinic, by the way, still exists. It's on West 46th Street, and West 26th Street, and it still operates under the same name all these over 100 years later. So this was one model for labor. Another model developed in the 1930s from groups like the left-wing fraternal group, the International Workers Order, and a few unions like the Transport Workers Union. And this was the idea of having a panel of doctors in the city that members of the union could visit at very low or no cost. So essentially, both these groups set up networks of physicians who they had a financial arrangement with, and the members at minimal a fee could visit these doctors. So, you began to get these experiments in the years before World War II, but these were just that. There were experiments, very few people were covered, they were innovative, but really labor did not get heavily involved in the provision of medical or hospital services. This changes with World War II, which really changes the politics and economics of working class healthcare. For one thing, it undermines the old models. The reason why you could set up these physician panels like TW and IWO is because there was a depression, and the physicians had no patients because patients couldn't afford to go to doctors anymore. So they were willing to participate at low fees. But with the war, the economy recovers, lots of doctors go into the armed services, those models fall apart. At the same time, a new model kind of begins to develop, which is military medicine. Millions of Americans experience a different kind of medical care, not based on the individual, fee-for-service, sort of small businessman physician model, but on a kind of industrial rationalized model of the army. So the war sparks a lot of thinking about going forward, how do we provide medical care? And two new approaches developed, which are still very relevant today. One was having employers provide commercial or even nonprofit health insurance to their employees as part of the employment relationship, either unilaterally or through collective bargaining. And this was sparked by a number of things, but one was very specific to the war. There were wage controls, and unions and employers could not negotiate higher wages because of federal controls. But they could sort of subvert this, or subvert's the wrong word, they could get a backdoor way of improving workers' lives by providing what was called then social benefits, what we would call fringe benefits. And the most important of these was health insurance. So, companies either negotiated or on their own began to offer their employees health insurance. It helped retain the workers, it made them happier. And the federal government, in effect, paid part of the tab because the companies could deduct the cost of their health insurance that they provide for employees from their federal taxes, right? So in effect, there's backdoor subsidization by the federal government. So that was one approach. The other approach was saying, let's get a national health system going, let's expand the social security system already in place to include medical insurance. And the key push comes in 1943, right during the war, with what's called the Wagner-Murray-Dingell bill, which was a bill introduced in Congress to add health insurance and disability insurance to the existing Social Security system. And this bill was introduced for the next half dozen years. And this was the preferred approach of organized labor. Across the political spectrum, more conservative, more liberal, AFL, CIO, the preferred approach of unionists was, let's have the federal government provide this service as a kind of national social program. The bill did not call for a British-style national health system, but instead it was really a funding system which was anticipated would fund all kinds of locally based systems, which might include things like prepaid plans like Kaiser Permanente, which was just getting started at that point on the West Coast, or more traditional fee for insurance, or strings of clinics that would be like group practices, and also would provide disability insurance. In fact, it's worth reading now. It's a very interesting broad proposal. And it failed. It failed. It faced fierce opposition from the American Medical Association, backed by conservatives and a lot of business interests. And although for a half dozen years there were big pushes to pass the bill, it collapses. The one piece that does get done on a state-by-state basis is disability insurance, right? That's the insurance that we have in New York State starting in 1949, which gives you payments if you can't work because of a non-work related accident or disease. So it complements workman's compensation and takes the income loss piece sort of out of the equation. Now, increasingly, the challenge is how do you pay for medical care? How do you pay for medical care? Well, with the prospects for national health insurance disappearing by the late 40s, a lot of unions now turn to different paths. And the dominant one was to bargain with employers, as had begun during World War II, to get health insurance for the members of a particular union. And this was aided in 1949 when the Supreme Court said that these kinds of fringe benefits were mandatory subjects for bargaining. So under federal labor law, which of course doesn't cover the PSC, but does cover most workers, an employer can't say, I'm just not going to talk to you about health insurance. They are legally obligated to engage in good faith bargaining. They have to agree, but they have to bargain. And during this period of time, a lot of unions, both very large ones like the auto workers, but lots of small ones, begin to bargain to get payments for health care from employers. Okay. So where's the money go? What do you do with it? Well, in the case of the really big companies like Ford or GM, they say, okay, we'll do this, but we're going to do it. We don't want the union involved. And they just go to big commercial insurers and they buy insurance contracts to cover their employees. Okay. But in New York, where you have mostly small employers, that model doesn't work as well. First of all, a lot of small employers, they don't know anything about this. They don't have an HR department. They don't want to deal with it. And the unions are powerful enough to basically force them to let the unions participate, even take the lead in devising how to provide healthcare. Okay. And in these situations, again, there are two tracks. One is you could take that money and you could beef up the union clinic model. So a lot of new union clinics begin to develop in the years after World War II. It's not just the ILG anymore. It's the laundry workers, the clothing workers, the hotel trades, the longshoremen, the building service workers. By the late 50s, about 500,000 New York workers had access to union clinics to get their health care. So that's a major medical system that was devised in those years. But that's actually not the dominant model. The dominant model is the buying insurance model. But New York had a twist, which was that in New York in 1944, the mayor, Fiorello LaGuardia, who correctly anticipated that national health insurance would fail, worked with various labor people and progressive healthcare people to set up a New York specific healthcare system, the Health Insurance Plan of Greater New York, or HIP, a nonprofit prepaid group practice plan. And to get this thing off the ground, what Mayor LaGuardia said was that any employee of the city of New York who wanted to subscribe to this new HIP service, the city would pay half the cost of the premium, right? Which meant that HIP had a starting base, and this was the beginning of health benefits for municipal employees. So this is the origin story of our own health insurance. Now, if you ever wondered why you couldn't just have one health plan, why you always had to walk around with two cards in your pocket, right? And you don't know which one to give in all these situations, it's because New York State had a law that said the same company could not provide both doctor insurance, what they call medical insurance, and hospital insurance. You can't do both. So what New York City did is it contracted with Blue Cross to provide the hospitalization in a package with HIP. So what's Blue Cross? Blue Cross was an invention of the hospitals before World War II. It was an insurance plan. It was relatively small. It was to try to keep patients coming to hospitals during the Depression. But after the war, unions began negotiating for Blue Cross coverage, and Blue Cross became a very giant enterprise. So these were the two enterprises that became the health providers for municipal employees and for a lot of non-municipal private sector employees too. A few points. The growth of Blue Cross, which, in many ways is a good thing, had unanticipated results. One is it undermined the public hospital system, because a lot of working class people who might have gone to a public hospital, if they got sick, Bellevue or Coney Island or something like that, began preferring to go to the so-called voluntary hospitals, the Mount Sinai's or the Montefiere's, because that would be paid for by Blue Cross. Blue Cross existed to channel people into those hospitals. And they got semi-private rooms, like the New York City public hospitals had wards, and it was a more modern, more attractive approach. So it undermined the public hospitals. At the same time, it linked the unions into the rising cost of hospitalization. Because if you're negotiating with the employer who provides, Blue Cross, and Blue Cross rates go up, the employer is going to turn around and say to the union, whoa, we're going to have to compensate for that money some other way. Okay. And this was a big problem. This is a big problem for one good reason and lots of bad reasons. The good reason was hospitals used to be cheap because they didn't pay their workers any money. The non-professional staff in hospitals in New York City was so poorly paid in the decades after World War II that many of them were on welfare, even when they had full-time jobs. But they began unionizing in the 1950s, and once maintenance staff, lower skilled staff, dietary aides, cooks, unionized, hospital costs go up because the wages go up. At the same time, there's ever more medical equipment, ever more expensive drugs, doctors get bigger and bigger sports cars, and the cost just goes up and up and up, which creates a big problem for labor. And labor pressures Blue Cross, which is nominally a nonprofit, to try to keep down costs, but only with mixed success. So by the time you get to the mid 60s, this issue of rising medical costs is now becoming a national problem, and the kind of political equation begins to change some. On a national level, this is when you get the passage of Medicare and Medicaid, which labor heavily supports and lobbies for. It doesn't directly help employed workers, but it does help the broader working class. In New York, the municipal unions begin getting more directly involved. Until then, the city pretty much unilaterally said, this is what we're going to offer. First, it was just HIP. Then they added GHI as an option and other options. But in the 70s, unions began to press to get involved, and the Municipal Labor Committee, a coalition of public sector unions, becomes the vehicle for negotiations over healthcare. These are separate negotiations than the individual union contracts. To this day, as PSC members, our healthcare is not guaranteed in our union contract. It's actually part of the municipal code, administrative code of New York City, but it's connected. And the whole mess we're in now is because the city basically said, we're not going to give you more money for wages unless we can save money somewhere else. How about saving money in healthcare? And then they came up with a scheme that, along with some unions who thought they would save money. So that's where we are today at the end of this long story. I've taken too much time, just a few stories, comments. In some ways, this is actually a success story. People don't worry as much about income loss. Working people have access to modern medical care, and unions play a big role in that. But it's a crazy jerry-rigged system, as everyone knows. No one would have designed from scratch a system like this. And each time the costs of medical care get cranked up, it gets creakier and crazier. So, obviously, it's a total crisis, and whether the big solution is Care for All or something else. There's a lot of debate, but clearly we can do better than we're at now. And so, there's a lot of challenges ahead of us.
Thanks, Josh. So I want to turn the floor over to Barbara Caress, who's going to talk with us about the paths not taken, the alternatives to the current situation where the city's trying to force us all into a private for-profit insurance plan. And so let me turn the floor over to Barbara.
Thanks, Jim. I want to begin by saying you've given me a huge promotion. I'm an adjunct assistant professor and you made me a professor. That's good. I appreciate it. Thank you.
You deserve the promotion.
Thank you so much. I've been an adjunct for 40 years, so it's good to get a little promotion. Can I get to the screen share? Is that okay? I can go there. Let's see. Can you guys see this? Is this visible? And my apologies to the people who have already seen this presentation. I'll make it a little bit different, I hope. Interesting for the people who have seen it as well as the people who haven't. Is this visible though? Can somebody tell me, Jim, can you see this? Okay,
yes.
Good. Okay, so I really want to make 4 points and talk mostly about what else is possible. And the 4 points are: the city pays too much for its health insurance, even as it's constituted now. Comparable insurance offered through other big collective bargaining agreements, and the ones I know best are 32BJ and 1199, get much more and cost less. And that has to do with the history that Josh did so ably describe, wherein both Emblem, which is the inheritor of HIP and GHI, and Empire are entwined into the finances of the city, and the finances of the city are entwined into those two insurance companies, and it makes it, number one, complex, and number two, too expensive. There's a built-in subsidy, which I can talk about, but let's just assume that I know what I'm talking about, and we'll move on a little bit. And because of that, it costs too much and you get too little. I'll talk a little bit about it, and then I really want to focus on the, as Jim described, the roads not taken in the points made in the 2018 MLC agreement with the city. At the time, that round of bargaining was contingent upon finding ways to reduce the city's health insurance costs. So, and I'll talk mostly about that. So quickly, I actually have to revise this number. It's actually approaching 11 billion. This is 2023. I've only got it up through 2021. But this is just showing you what the city's spending. It's a lot of money. This is a very significant expenditure by the city, which it has willfully and deliberately neglected to manage. It contracts it out to Emblem and Empire. It has a very, very modest operation management group in OLR, which has nowhere near the capacity that it would need to manage an insurance plan that covers 250,000 people. I'm sorry, that covers 1,400,000 people. Just to give you comparable, 32BJ covers about a little bit less than 200,000 people. It has and it's all insured. It's all done through insurance companies, which I'll explain how that happens. It has a health fund staff of more than 15 people and a health fund research staff of 5 people. The city has nothing like that. It has a couple of people who work on health insurance. And it's important to keep that in mind as we move forward. this is fiscal year 2021. And basically, if you guys had the same benefits, no out-of-pocket, no co-premium for the participant, as 32 BJ or 1199, it would cost the city about $500 million less. So that's just to tell you that your system is already inefficient, even without making any changes. That there are ways that what you have both active and retiree could be much less costly. I'm not going to do the history because Josh has done it. Let me get right to what else could have happened. This, I don't know if can see this. This is a page from the MLC agreement. And it lists 8 alternative ways that the Municipal Labor Committee agreed that the city and they should consider ways to reduce the city's health insurance costs. One of them, as everybody knows, is the turning the post-Medicare retiree benefit over to Medicare Advantage plans. But there are others, and the list is interesting. I want to talk just about 2 of them. One is self-insuring, which I'll go to right away. And the second is reducing the cost of hospital care. Hospitals constitute between 35 and 40% of your claims costs. And so if the price of hospital care will lower, the cost of health insurance would be lower, just to say health insurance, commercial health insurance of the size of a group that you are, which is gigantic, is obligated by law to spend at least 85% of its premium on claims, meaning at least 85% of its premium on medical care. So if you take that 85% and say, well, let's say, 40% of it is hospitals, that's a third of your total, roughly a third of your total cost. If you could reduce the prices of hospitals, you could reduce the cost of health insurance. But let me talk about self-insurance first, and then I'll talk about pricing. Self-insurance, and this is to say New York City is extraordinary in the fact that it buys commercial insurance. No employer of this size, and I believe all but 2 states, self-insure. Self-insure does not mean they run the plant. Self-insure only means they take the risk. The insurance company, which in the case of self-insurance is no longer taking the risk, but it is running, the employer or the fund makes a deal with an insurance company and says to the insurance company, we want your negotiated rates. We want your network. We want you to pay our claims. We want you to do everything you did when we were commercially insured, but we don't want to pay you for assuming a risk that we're willing to assume because we can save money that way. So I just want to talk about self-insurance without having everybody panic that I'm talking about the city of New York administering your health insurance. I'm not. Although, let me say they could. 1199 not only self-insures, but self-administers, meaning it doesn't use a insurance company to run their benefit fund. They run it themselves. They have hundreds of people who work in the fund office, and that's what it would take to do it. But it could be done, and there are reasons to do it. It also could be done very, very simply. At 32 BJ, we contracted with Blue Cross, and we said to Blue Cross, okay, you provide the benefits, we'll take the risk, and we'll save money. And let me show you, and not only on the risk charges, but also on premium taxes. The state of New York collects a premium tax of 1.75%. You can multiply that times 11 billion, and you can see that the city is actually subsidizing the state by buying commercial health insurance. This is a little diagram, I'm sorry, a little diagram that just shows you typical insurance, where the health insurance premium dollar goes. 85%, as I said, it goes to claims. And in the case of insurance company, there are some administrative costs, and there would be if you were doing it yourself, although the city's administrative costs would be nominal, because one of the biggest parts of administrative costs is collecting premium. It's billing and collecting premium. And of course, the city doesn't need to do it, just needs to pay it out of its coffers, out of its tax revenue. Secondly, is what they call margin. Actuaries call margin, and I call risk charges, meaning the no insurance company, no competently run insurance company loses money. They might lose money 1 year for having gotten the projection wrong, but they have lots of money in reserve. And that money in reserve, they add to every year by adding a small percentage of the premium. And again, let's say 2 or 3%, 2 or 3% of $11 billion. This is a lot of money as a risk charge to build up a reserve in case they're wrong, or in case there's a pandemic and their expenses explode and they don't collect enough money during that year. That piece of typical commercial insurance premium is gone if you self-insure, and also gone are the taxes. So there's a lot of savings to be had by doing nothing other than changing the financial relationship with the two insurance companies. I say that as if it was simple. It's not simple. It would be immensely complicated, because both, particularly Empire, but also Empire, are very dependent on the extra revenue that they get from the city that's been built into their premiums and is codified in the city's administrative code from a time when the city wanted to subsidize those insurance companies on the principle, which LaGuardia established, that if the city subsidizes the insurance companies, it would make the cost of insurance for non-city employees, for other city residents, lower. And that's built into the rates, and it's been built into the rates for almost 80 years. The one other thing I want to talk, I don't want to take up too much of your time. One other thing I want to talk about is claims costs. And as I said, hospital claim, let me use 1199 as an example. 1199 does its own negotiations with the hospitals, and it has special leverage, of course, but it buys hospital care for its members and their dependents basically at Medicare prices. And Medicare, particularly for inpatient care, pays substantially less than commercial insurance. And there are a whole lot of reasons for that. And if you're interested, I could do a whole other session about what is it that accounts for excessive pricing of hospital care in New York City. But if you could, in coalition with other unions, through political activity and legislative activity to contain hospital prices, there are substantial savings to be had. So just to conclude, I want to say, so these are two solutions: self-insurance, hospital pricing, which in no way change your health insurance arrangements. They just make them cheaper. There are other solutions, which we don't have time to talk about tonight, that would in fact reduce your healthcare costs, because the system itself is, I would say, corrupted, is profoundly misaligned to people's needs. And there are other kinds of strategies that the city could employ to begin to reform the health system, but that's for another session. So let me stop here, and I guess, Jim, if the, is our other speaker here?
Well, I'm looking, Naomi, have you arrived? I don't see you in the list of participants. I don't know what's happened. I know she was out of town. She was connecting from out of town. I guess Naomi Zudi will have to be for another time. She was going to talk about the impact of the healthcare, health insurance options that were available to working people. We focused particularly on the CUNY community and students and their families. But I think we have about 15 minutes where we could entertain questions from the audience. So if you would use the reactions icon on the lower right-hand part of your screen and use the raise hand symbol, or put a question in the chat, Anais will try to keep a stack and with assistance from Bill Friedheim, and we'll take your questions.
There's a question in the chat from Gloria. Jim, would you like me to read the questions out loud, or what would be?
Well, if Gloria's on, can we just unmute her?
Hi, yes, I'm here. So I think if I understood the presentation, that the insurance companies charge more money because there's a risk factor. I don't know what that means. So my question is there a risk to the union if they do self-insurance?
No, yeah, not to the, well, there is in fact, that's a good question. There is in fact a risk. And the risk is that the claims come out at the end of the year to be more than the premium, that the money that was collected, or the money that was spent, or the city's money that was allocated. That happens from time to time. On average, it'll happen once every 5 or 6 years, that the actuaries get the predictions wrong. And so the assumptions about what the year is going to cost are wrong. And there are two different ways employers or union funds deal with the risk. And one of them is to buy stop loss insurance, which is to say to buy insurance, again, that gives you some protection against excessive claims. In the case of a group like the City of New York, it doesn't need to buy stop loss insurance. In insurance language, a group is credible from the perspective of the actuary, from the ability to predict next year's expenses from last year's experience. It's credible when it has 1,000 people in it. And New York's plan has well over 1 million people in it. It would be extraordinary if they made a bad prediction. It's almost impossible. It's almost impossible other than extraordinary circumstances. For example, a terrible pandemic which sickened tens of thousands of people, and there were completely unexpected costs. If that happened, those costs would have to be recovered in future years in the same way that the insurance company would recover the cost. So is there a risk? Yes. Is that risk measurable? Almost not. It's almost infinitesimal.
Thanks.
We have Roberta.
Yeah, thank you. I really appreciated those two presentations. My question, I guess, is more for Barbara than it is for Josh. In the HIP model, the doctors could have private offices, but they also had to work out of a common place, so that if you saw a specialist, he or she, was mostly he those days, was in the same building as your other doctors, and they could all look at your records and so forth. Is this a model that 1199 also uses, or any of the other union-connected medical plans?
It's close to the model that the hotel trades uses. 1199 doesn't. 1199, members get their benefits the same way you do. But hotel trades has actually a network of clinics, specialty clinics where people go and get their care. And in fact, if they live in the city, they can't go elsewhere. They have to use the clinics. It's a really interesting model. And it's one of the things that is worth thinking about going forward for the city benefit plans is, does it make sense to organize large multi-specialty groups that are for city employees and their dependents? A question I think that's worth asking. I don't have an answer for right now, but I'd be happy to come back and discuss it with you.
Thank you.
Can I jump in there? Because I wanted to add something about it. One of the problems with the union clinic model was suburbanization. It really worked well when people lived and worked in relatively compact areas. But as people started spreading out, it was very problematic. And this is also a huge problem for HIP, because HIP was blocked from moving into the suburbs by the local medical associations that didn't want the competition. So
it's actually why we got GHI as an alternative for
Right.
city employees. Thank you, Josh.
Yeah.
I have a question from Audrey in the chat. Audrey, would you like to speak to your question?
Yes, so Barbara, you were talking about reducing hospital costs. And I understand there's something called observation, where somebody is in a hospital. I was in a hospital. I was under observation, meaning the insurance company was not going to be billed as if it were an admission, although actually I received all the care that I think a hospital admission would receive. I think it's a way to limit or reduce your ability to get post-hospital care. But what is this all about? And does this have something to do with reducing hospital costs that you were talking about?
You know what it has to do with? Was created by the hospitals. Initially, there were, people who were in the ER who needed to be observed for 24 hours and they were held in the ER. And that's not what this is. When after 2003, Medicare system started to penalize hospitals if there were readmissions within 30 days. And the reason for that was that hospitals were extremely irresponsible about follow-up care for their own discharged patients, and Medicare was bearing the burden of that irresponsibility. Too many people were sent home sick and readmitted pretty quickly. So Medicare dealt with that problem by saying, okay, if you readmit somebody within 30 days of a discharge, unless something else has happened, we're not going to pay for it. So the hospitals actually found a way around that, which is the observation days. So the observation days don't count against the 30-day calendar. This is one of those most bizarre things. Nobody likes it. Patients don't like it because it means you're not entitled to transfer to rehab or skilled nursing. Hospitals hate it because it undermines their income to some extent. And Medicare increasingly is looking for a solution to it. This is not a good way to deal with the fact that Medicare tried to fix something. It's a yin and yang. Our regulation of the health system is the feds will do something, the hospitals will respond, and the feds will try and respond. And as a result, we get regulations that cover, rooms. But that's a short story about the observation days.
Thank you.
Bill?
But also, do the hospitals pay, do the insurers pay less for the observation days?
No,
Did the
not.
insurance-
Basically, it's a Medicare it's essentially a Medicare issue, and it's nominally less. It's not much less.
Yeah, I'm
Bill?
going to ask a question because I see no other hands up. And maybe I'm opening a Pandora's box. Maybe that's a good thing, but you kind of teased us about the relationship of Emblem and Empire to New York City, and that, I don't know if I'm putting words in your mouth, but essentially the city has thrown a lifeline to both companies. I don't know if there's time, but if you want to expand on that, I would like to hear more.
Sure. We really need Debbie Bell to do this. She's the expert. So I'm going to do this without Debbie's expertise. I'm going to do it as an outsider. She can do it as an insider. But essentially, as as Josh said, LaGuardia when they created HIP, they seeded the idea, SEEDED. They seeded the idea that the city would help HIP get on its feet, because HIP was created as a system for New Yorkers, not necessarily a system for city employees. And LaGuardia's offer to city employees to participate in HIP, and the city would pay half the cost, was a way to get money into a system that was just being built post World War II. And that relationship between the city and HIP is central to HIP's existence, and it continues to be central to Emblem's existence. Emblem is a, quote, nonprofit insurance company. It manages to lose huge sums of money, and it is kept financially stable by virtue of the fact that it is the principal insurer for hospital care for city employees. And so if the city, and built into that are the risk charges, that's gravy. But in the case of Emblem, that's essential. And if the city were to withdraw that, there would be a crisis. And Emblem is important not just to city employees, but it also has Medicare managed care contracts. It provides services. It provides insurance to other city employers, as well as their Medicare Advantage plan. So it would be destabilized, I think. The issue with Empire is a little bit different. Empire, as Josh said, as Blue Cross organized, the hospitals organized Blue Cross as a way to pay their own bills. And one of the, and essentially the way Blue Cross functioned was at the end of the year, it would say to its insurance company, which was a wholly owned subsidiary of the hospital associations, we spent $1 million on Blue Cross patients, so we need $1 million. We spent half of our cost was $2 million. Half of our patients were Blue Cross. We need $1 million, and the company would give them $1 million. If in the next year they spent $4 million and half of them were Blue Cross, they would say to the company, "We spent $4 million. You have to give us $2 million." So, and it was a quite an incestuous relationship, which got memorialized in Medicare. Medicare's hospital, Part A, Medicare Part A, was designed to replicate Blue Cross. And it's an incredibly inflationary model, of course, because the more the hospital spent, the more money they would get. But that was part of the political deal the Kennedy and then Johnson administration made. American Hospital Association, which was the overseer of all these Blue Cross plans, it said, we'll pay the hospitals the same way Blue Cross pays the hospitals. And not only that, we'll give Blue Cross the business to process Medicare claims. That was part of the political deal that got us in 1965, that got us Medicare and Medicaid. That turned out to be very, very expensive, very inflationary. Blue Cross was, the AHA was forced to divest itself of Blue Cross in the early 70s. I'm going to jump to New York because it's an important piece of the story. And I'm sorry for making this complicated. I don't mean to. And but because Blue Cross was not an insurance company, it was a hospital service company, meaning it wasn't insuring people in exchange for their monthly premium. It was guaranteeing them a service. And it was in the 60s, 70s, 80s, and especially 90s, it was the only company that was community rated, only hospital insurance company that was community rated, meaning that they didn't cherry pick, that anybody who wanted to buy Blue Cross had the right to buy it by virtue of state law. The way the state legalized this hospital service company, it forced it to be community rated, forced it to sell its product to anybody who needed it. Post the AIDS epidemic, so Blue Cross was almost bankrupted by the AIDS epidemic because all of a sudden this apparently healthy population was desperately ill and very expensive. That's actually an important part of the story. So the state helped by saying that Blue Cross could charge less, have a competitive advantage to do so. I'm really sorry for taking so much time. It really is a complicated story, but the city and the state were subsidizing Blue Cross because they wanted to retain a hospital services insurer who was available to everybody and could not cherry pick its patients. So that piece of history is built into the history of the premium that the city pays to Blue Cross. The way the premium is established is you take last year's experience and you trend it forward. So every year that the city buys insurance from Blue Cross, it's buying it based on the prior year's expense. And so if the expense is 1,000 and the trend is 10%, next year's premium is 1,100. No one ever challenges what were the components of the previous year expense. And again, I apologize for the complexity of the answer. It's a good question and not an easy one to answer in a short time.
Well, Josh and Barbara, thank you very much. This has been really, I mean, we got into the weeds somewhat, but this is part of a critical education if we're going to move in the direction of a more progressive healthcare policy. So thank you both. I want to thank all the participants in the session tonight. Please fill out the survey, the link to which is in the chat. And we'll stay in touch. This is only the second of a series of sessions on the healthcare crisis, and we're moving in the direction of trying to find the way to go. So thanks to everybody for their participation, and we'll be in touch. And my particular thanks to Anais for orchestrating this evening. She's the Associate Executive Director of the PSC, and her help tonight was invaluable. So thanks again to everybody.
Thank you.
Thanks.